Now I get to talk. So as we go through this journey for our patients and talk about adjuvant and metastatic therapies, et cetera, our talks became really keyed on BRAF therapies and checkpoint inhibitors. But in the back of our head, there was always the idea that there was more. There was stuff being done in small areas. Oh, there we go. In regards to T-cell therapies and TIL, adoptive T-cell therapies. And I'm amazed and impressed at how far we've come over the last couple of years with these therapies and how available they are. Again, I'm going to begin by saying, when you get another tool in your toolbox, you have to understand that it's just not there to be used later. We have to try and seek those answers. Who does better with one therapy over the other? Where does it fit in, and where do we go? Because we're not just answering these questions for melanoma. We're, again, as I've always said, answering them for other solid tumors. So these T-cell therapies, even though you're tuning in and you're a melanoma person, these really do and will address other solid tumors: lung cancer, ovarian cancer, cervical cancer, et cetera. These are my disclosures for you. And the answer is always, look, it's in you. You know, what are we doing? A lot of this discussion has been that it's you, it's your immune systems that are fighting cancer, because cancer is just a foreign invader, just like a virus is, just like any infection is. And we have to take this beautiful T cell, which is your immune fighter cell, and get it to the tumor, figure out why it's not working with the tumor. We know that it's not working because we're targeting those checkpoint inhibitors, which decrease the activity of these T cells. And we don't talk much about our pharmaceutical partners, but they're understanding also. You can see here, these are the cell therapies that are coming through the clinic, and they are increasing yearly. So it's not just one company, one person, one type of therapy. Hopefully I'll take you through the gamut of these and talk more about it. IMTACs. Immune mobilizing monoclonal T-cell receptors against cancer. Dr. Sullivan began talking about them in the fact that it's a negative connection. I call them matchmaker therapeutics. They're antibodies that at one side bring the T-cell, on the other side, they bring it together to the tumor. As you can see here, on the top right, you give this ImmTAC on the top, the T-cell receptor targeting area on the bottom, the one that targets the tumor, and you give it, it connects the cancer cell to the T-cell, and it's almost like a Yenta matchmaker. It makes a match that is toxic, but it's appropriate. And this is the reason why we feel that some of our therapies fail to work, is because you cannot get these two together. You know, you can't get the tumor, the T cells into the tumor. How can we do it? And these drugs are doing that. And well, how are they doing it? Well, they're targeting these specific antigens. You heard a lot about antigens. Dr. Memi started talking about them as far as neoantigens. These are novel proteins, novel antigens that are on tumor cells that don't belong there. And as far as tebentafusp, we talked about, that targets GP100. There are other drugs, so they're coming. They're a broad-based base of them that are coming, that are specific for multiple different antigens. And this is the PRAME drug made by the people who make tebentafusp. But what does it do? It brings the tumor, the T cells into the tumor, and it targets an antigen that's expressed on a multitude of cancers. I say, look there, it's high expression, that dark, rich olive green, melanoma, endometrial, lung, etc. Don't look at the numbers. If I show you numbers, don't look at the numbers. Look at the colors and what we're trying to say, the broad strokes. This shows interferon gamma induction, like those are things that's interferon and a stimulus that brings tumors, T cells in and causes an inflamed environment. And on the left, you see one where you give the drug at higher doses, it causes interferon gamma to go up. In the peripheral blood, your T cells, like those blood tests that you take, they give you all these numbers and you don't understand any of it. You're like, well, I did my white cells are good and I'm not anemic, but the lymphocyte count goes down in your blood. Why? Because it's trafficking. It's no longer in your blood. It's to the tumor. And that's what those beautiful pictures show. I was never really good at pathology, which is okay because I may be out of a job because AI is going to replace pathologists, I hear. But you can see the CD3 staining, that's the T cells. It goes up a huge increase as you give this drug. And this is just the data from the PRAME drug. Again, Dr. Sullivan educated all of us. If it's going down, it's decreasing. So it works in uveal melanoma, cutaneous melanoma, ovarian cancers where we're seeing responses, lung cancers where we're beginning to see responses. And I didn't put it up there. It's always good to put up an scans. You can see on the top baseline, on the bottom, after some initial therapy, shrinkage. This is one of our patients who was treated with what was standard, anti-CTLA-4, multiple anti-PD-1s, multiple injectables, and then came and said, I don't have another option. And we gave her this therapy and it helped. And we now, when patients come, we screen them for whether they need to be on this therapy and go forward. If you come to see me, part of your therapy, or if you see Dr. Sullivan, Dr. Patel, Dr. Matt, part of it is, I need to get your tumor genotyped. I need to get circulating tumor DNA, and I may need to check you for the type of patients who are appropriate for this therapy. You've seen this, but I'm going to take another part of this. This not only showed that it works in cutaneous skin melanomas and ocular eye melanomas, but it also showed that it's very tolerable with not just an anti-PD-1 approach, but an anti-CTLA-4. So you can triplet combinations do work here. And it's a different therapy. So you can see how you can prime by giving this drug, bringing the T cells in, and boost by giving a checkpoint inhibitor to allow the immune cells to remain active once they get in there. You just saw this in a better fashion. So it's coming in melanoma. One of the interesting thoughts here, and this is from Dr. Carvajal, who is great in melanoma and is now leading a huge cancer center. But this is a patient, you don't need to read all that, ovarian cancer, received all of the checkpoint and not ovarian, ocular melanoma, received all of the therapies, didn't do well, came on to one of these IMTACs, which was tebentafusp, and then had some benefit. It stopped benefiting them. And then they went back onto drugs that they had seen before and had a great response that's durable. Why? Because probably initially this person didn't have those T cells in the right area. And then you got the T cells in, and then you came back with a checkpoint inhibitor and it worked. This is amazing. Yes, it's crazy that this works, but it's proof of principle. And it shows the one thing, that the power is really in you. This one patient's experience informed us more than a 30, 50, 60 patient trial. It informed us on how to move forward. So look at all these prior therapies. I mean, and then did well after that. So I steal that from him. And this only says that we are not done exploring combinations with these T-cell therapies. This trial is open at a place near you. And it's not just, you could get a lot from here. So we're looking at it in ovarian, endometrial, non-small cell lung cancer, now triple negative breast cancers. in sarcomas, and not just in single agent, but there are expansion cohorts with chemotherapies, expansions with anti-PD-1 therapies, and combinations of these MTACs. So there's an arm there for ocular melanoma patients to not just get this PRAME agent, but to get the approved agent tebentafusp. And we can see how we're mimicking what we've done before. Get one drug that works, a similar drug from the same class, see if they work together, see if they work with everything else, and then we're moving forward. Now, a lot of hubbub is coming from adoptive T-cell therapy. When I used to talk about therapies for metastatic cancer, I used to only spend one slide on it because I couldn't do it. I didn't want to talk about therapies that I didn't give and I didn't do, and it was hard to get access to them. And now, I told you I wouldn't show you a lot of numbers, but this is second line post the initial therapies. Now these TIL therapies are showing the highest response rates after initial checkpoint inhibitor. That's all you need to take from them. How does it work? Well, let's say you show up here or anywhere else, you need a surgeon. So if you showed up at MD Anderson, Dr. Patel would introduce you to Merrick Ross, lovely guy. If you showed up at Mass General, Dr. Sullivan would introduce you to Dr. Boland. She does your surgeries. And if you came here, you would be introduced to Dr. Ferries, and the patient, those are areas of tumor. They get a surgical removal of the melanoma, and they digest that melanoma easily. Simply put, just like we talked about utilizing the T cells that are in your initial tumor in a neoadjuvant approach, this takes that out and brings those tumors that are already there, that are specific for your cancer, and it expands them. Why? Because we may not be enough cells. We may not have enough of the T cells. You may need to staff that tumor with more of these T cells. They expand them. And this is the part where we couldn't really do it because we didn't have the labs to do it, the clean rooms and the staff, et cetera. Now our pharmaceutical partners are doing this, locally. So Ferries does the surgery, sends the tissue off, and this is done in Philly. So Iovance is a company that we work with that's doing this. It's an interesting place they do it. It's very lovely if you ever get to go there. It's across the street from the Spectrum, so you can go see their facilities and catch a 76ers game. But then they send it back to us. The patient gets a regimen that gets rid of their T cells that are non-specific for the tumor. They get the infusion of the TIL in the hospital, and then those T cells are agitated to get into the tumor with IL-2. And so once they're infused, they get into the circulation, they migrate, they recognize the antigens in the tumor because they were specific for the antigens in the tumor, and they cause lysis, which is just a good word for death. And I don't like to show icky pictures, but this icky picture shows what can be done, and continue to be done. You can see the most impressive part is what happens months and months past, because this is a one-time therapy. One-time therapy. You don't have to come back for it. You don't have to, but our trials are looking at how to do it centrally. This is the trial that did it centrally. This is the trial that showed that places that are as small as ours, because never would I get in front of you and say that we're as big as Mass General, Harvard, or as big as MD Anderson. If you were paying attention, Dr. Patel's huge first slide showed this place, and I was like, is that Disneyland? It's so huge and beautiful and well lit. But it's just MD Anderson. It's huge. But places like us, we could do it, and this means that anybody can do it in any center in any state. As an aside, cohort 3 looked at retreatment, and we'll see if we can retreat. These are swimmer's plots that just show that you can get early response and they're durable. Just pay attention to the bottom. It's just nuts. And you can see the power of this therapy months after you've given one therapy. This is interesting because it shows It's a lot to read, but it shows that it works in patients whose initial response to the standard therapy was no response. Okay. So you can give the same types of therapies, but you may get the same results and you may not be going down the right path. And this indicates that if you're not getting a great result, at the first pass with what's standard, you may need to go to another approach. Well, what about earlier and earlier and earlier? This is done. This is John Hannon's data, and it was presented at ESMO, but published in the New England Journal of Medicine, same as where Dr. Patel's data was the highest journal of the land. And this looked at something different than what I showed you before. Before it was they'd seen the BRAF targeted therapies, and the average number of regimens the patients had seen was somewhere around 3 to 5. This is right after just seeing PD-1. So patients were randomized to going on to the CTLA-4 drug you heard about, which would be a standard second line, versus going into TIL therapy. And what they saw, and you just need to take a look at the response numbers, 41 versus 18%. So a higher percentage of patients responded. A clinical benefit is not just responded in shrinkage, but staying stable, or all those patients that were going under the waterfall plots, and still higher, 57 versus 33%. And progression-free survival, how long did that hold? How long did that hold the patients from needing another therapy or having growth? And the red is the adoptive T cell therapy. The blue is going on to anti-CTLA-4. And much better, of course. And you're starting to see a plateau that maybe those patients who were many months out, like 84 months out, they'll never need something else again. So that's the promise of this therapy. While this was a small trial, it did show us that we can bring it earlier. We didn't spend a lot of time, and don't really spend a lot of time, talking about brain metastases, because we know now that these therapies get to the brain, which was a place where we were really without any type of therapy in the past. This is data showing that this adoptive T cell, this TIL therapy, gets into the brain. And just a push to say that clinical trials are also looking for it. This is Alison Betoff-Warner, who is now at Stanford, and she has a trial looking at patients with live brain mets, like that haven't been treated, looking at how TIL works for them. Well, what about earlier and earlier? This is a lovely trial that's been presented as ongoing, looking at first line when you're first diagnosed. What if I give you a checkpoint inhibitor, this PD-1 drugs that we've been talking about, which is the standard backbone, along with TIL? And again, so thank you so much for teaching everyone how to look at a waterfall plot, because this is extremely, extremely promising. A small numbers of patients, but nearly all patients with melanoma had an initial benefit. It all goes down. And then it stands to push the idea that these are not just for melanoma. The second group are head and neck cancer patients. And the third group are cervical cancer patients. And I wouldn't sit here and tell you that melanoma is unimportant, but I would say the idea of finding something for cervical cancer globally is a huge problem. And look at how well this works. We're now accruing to this trial, which is knocking out PD-1. The PD-1 inhibitors try to block PD-1 on the T cells. This knocks out through CRISPRing. I'm just going to use a buzzword, CRISPR. It just takes out, so these cells don't express PD-1. So you can just give this TIL alone. And now that's looking at unresectable metastatic melanoma, but also non-small cell lung cancer, another place where we have problems with getting benefit. Preclinically, this shows that it is working better than others. What about a smart T cell? How can we make T cells smarter? And this is a trial, actually it's running at MD Anderson, of a drug from Obsidian. The cell itself expresses interleukin-15. There's another interleukin stimulate the immune system, so that you don't have to give interleukin-2 in the hospital infusionally. It has a linker right here. And by giving a pill, you can cause the expression of IL-15. If you run into side effects, then you can stop giving the pill and you don't have those side effects. So that's wonderful. So that's TIL. What about CAR T? You hear that because our friends in liquid tumors like lymphomas and leukemias have benefited this. It's like putting a honing mechanism in the T cell. You don't need a surgery here. So Dr. Ferries doesn't need to be here for me. The patients go and get an apheresis just in the place where you donate blood. And instead of taking your red cells, they take your T cells out. It goes into a lab where they transduce, which means they just place in it. They modify the T cells to have a heat, like a heat-seeking missile, to have an antibody that targets a specific protein on the cell. Heat-seeking, just like I talked to you about the ImmTACs, where it has an antibody that takes you to the tumor and an antibody that brings the T cell in. Now you don't need that part that brings the T cell in. The T cell itself goes directly there and has to go directly there. It's like when I tell my son, you got to go meet this woman's daughter because you two are going to get married in 15, 20 years. Directly focused. Don't look anywhere else. And they expanded the same way they do for TIL. And then you get the chemotherapy, the infusion, and go forward. This is a trial running out of that has finished and accrued out of UCLA. And you can target specific proteins. This is the Imantix drug, which does the same thing, but it targets PRAME. Just like I talked to you about the ImmTAC that targets PRAME, these T cells target PRAME. And you can see that it causes shrinkage of tumors. I'm not much for the radiology. Oh, well, why is it so important? Because it's proof of principle that you can use these drugs in other settings. And this is not a melanoma. It's another solid tumor, but this was presented and I really loved it. They took the CAR T cells and instead of infusing them centrally, like giving it as an IV and it goes throughout your body, they give it directly into the brain. And you can see some of that stuff around the spine just begin to melt away. So these are the futures of these therapies. And I'll spend a little bit of time talking about NK cells. These are natural killer cells. They're other cells that your body have that attack tumors. There's a phenomenal person at MD Anderson who's at MD Anderson, Persian like me, and the lab is looking at how to utilize these NK cells, not just her name, Kathy Rizvani, but her company and other pharmaceutical companies are looking forward to bringing this NK cell therapy. It's great. I'm going to show you single agent, but I think in the future, what's going to happen is these are going to be given into the central nervous system. These are going to be given along with PD-1 inhibitors. These are going to be given along with TILs. And you're going to come and we're going to take, at the beginning of diagnosis, take your tumor and do these things for you and have these things available for all patients. What's so great about them is that these cells, these NK cells, don't really need to come from you. Allo NK comes from another patient, is being looked at. They're looking at decreasing the need for lymphodepletion, so you don't need to get the chemo to get rid of the other T cells. So you can have this off the shelf. So if someone doesn't do well with the initial therapy and they say, oh, great, now I got to go see Ferries. He's on the second floor here. Then I got to wait until my TILs are made. You can say, all right, while you see Ferries, this is off the shelf. I got it. It's in here tomorrow. Get your surgery, heal, come and you can get this. And interestingly, we've seen it work. And we've seen it work in cancers that really don't respond to any other types of immunotherapies. And we've seen it work in cancers that have failed initial PD-1 therapies. This is NKGen's data. I think it's auto NK, but it's NK cell therapy. These are patients that really don't respond, that have failed standard therapies. And you can see here, that in these patients, they have response and durable response. So proof of principle is great. I love this slide because it helps do 3 different things. 1, it shows the future. 2, it helps as I come to the end and have to introduce the next speaker. The gentleman who's the chief medical officer here is a radiation oncologist that I knew very well, who worked in the community and then believed in this so much and started to work with this company and is now bringing this drug not only to patients with other solid tumors, but with to melanoma, and we'll be opening hopefully their trials soon. You can see the sarcoma patient went through chemo, and also Keytruda PD-1 therapy and didn't work. And now the amount of benefit from this therapy is visible. And there are trials looking at it for metastatic to the melanoma, metastatic to the brain coming, HER2 positive glioblastoma. So even brain tumors they're looking at it for. And also complexing. This comes from MD Anderson Cancer Center, but this comes from the Rizvani lab. And it is complexing allo, that means from someone else, NK cells with bispecific cell engagers, which are ImmTACs, putting them together and then putting them in your body. So not only are you getting the NK, but you're getting these bispecifics together. And this has been shown to really work in other solid tumors. So in conclusion, we're working towards improved survival. Not only are there different pathways that Dr. Sullivan showed you, like red ERK, red RAF, red RAF, brown RAF, RAF, but that whole pathway, RAS, RAF, RAC, EK, PERK, but many new pathways immunologically. So these 2 concepts are coming together. There are new standards in the first line, second line options, expanding brain metastasis options, and they all come through clinical trials. So someone says, why clinical trials? Well, because the benefits can come earlier. And the other point that I really always say, I need to make this point, but I fail to make, is we're moving so quickly that, and the survival for metastatic melanoma has increased so much that you can be diagnosed, go through your first line therapy. There could be a trial that's accruing at the same time. And when you need it, that trial has already accrued, already data, already has the availability of it for you. And that's the new paradigm. How quickly we can get these things into the clinic to our patients. It was not like that when all my hair was black. It just was not. And now it is. So with that, I think I've introduced you to the T cell, and I can end. Oh, I forgot imaging. We can now also image to see if these cells are going to the right place. And all of you know how to do a PET scan, but these are PET tracers that don't target tumor, they target the T cell. So you can begin, get a PET, see where your T cells are. Oh, they're not in the right place. I need to target with T cell therapy. And then give those T cells or give the PD-1 therapy and then say, hey, let me get a scan at like 2 to 4 months and see if they're there. If they're not there, you got to go to something else. And it may be better than, or it may be able to augment circulating tumor DNA and things like that. And with that, I'll thank you.